talk about, I forget.
Is it okay if we go with that?
Yes.
Let's see. I'm going to talk loud, I think, instead of the mic. I'm not quite sure why it doesn't pick up. But this is a topic that's probably near and dear to most of us, because most of us that age category where something like this might happen. So let's just look at one with the other. So these are my objectives for today. I'm going to split this into two parts. Part two is going to be the next meeting, because this is it would take 25 to 30 minutes to go through the whole thing. Liz says 10 minutes to talk. So I'm going to limit it to 10 or 12 minutes. So I want to talk about different kinds of dementia. Well, we're talking mostly about Alzheimer's because that's the big one. Talk a little bit about the progression of the disease. And again, it will depend on which type of dementia it is. Talk about why we, as hospice people, want to know about the signs of dementia. And then talk about non-pharmaceutical treatment and pharmaceutical treatment. So this is the definition of dementia. Condition characterized by progressive or persistent loss of intellectual functioning, especially with impairment of memory and abstract thinking, and often with personality changes resulting from organic disease. I'll let you kind of read this. This is just another one, inability to problem solve, emotional control, behavioral things, and bottom towards late stage, you start seeing this agitation, delusions, hallucinations. So here are the types of dementia. Okay, everybody pretty much knows about Alzheimer's. There's another one is Lewy body vascular dementia. We'll talk about that a little bit. Traumatic brain injury is CTE is chronic traumatic encephalopathy. That's the football player thing where they get dementia. Parkinson's in its late stages will frequently cause dementia. Metabolic means there's something messed up, whether it's liver, kidney, etc. And then drug-induced dementia, which means you're taking something that's either conflicting with another one, or that particular drug doesn't suit you. Okay, so Alzheimer's is 60 to 80% of all dementia. So by and far, it's the biggest contributor to this. And as most of us are baby boomers, okay, so the number of people with dementia, Alzheimer's is going up because as the people are getting older. And these are sort of the three types of Alzheimer's: early onset, late onset, and familial. Okay, over 6 million people in the United States have Alzheimer's. It occurs in 1 in 9 over age 65. So look around, there's probably 2 people in this room. And we probably know a whole bunch of others, and then there's over 3 million cases every year. So huge, huge, huge impact in the United States and actually around the world. So early onset, usually before age 65, but usually around age 50, tends to be more aggressive, meaning that it progresses rapidly, because Alzheimer's has a timeline of around 10 years to 2 years from diagnosis to death. This one tends to be fast. Early detection may help slow it down. If you have some medicines, there are some medicines that may slow it down some, so the sooner you find it, the better. Often there's a familial connection, so it'll be in the family. Late onset is the one that's going to hit most of us if we get it. Most common form, usually after age 65. Progression from onset to death can be as long as 10 years and as slow as 2 years. So it can take quite different courses in different individuals. Familial Alzheimer's is one where we see it in the families, and you look for 2 generations that have had Alzheimer's, assuming that they live long enough. So if somebody dies at age 45, they might have had an Alzheimer's, but you'll never know about that. About 60% of those, this is early onset, they end up being familial. So you'll see it in the fact of the early onset ones. And in 25% of all cases, there is a history in the family. So when you hear that mom had it, dad had it, grandma had it, grandpa had it, that would be some, doesn't mean you're going to get it, just means that you're a little bit more likely. so why do we want to know? Well, there are several things. We're not getting into homes yet, but when we start getting into homes and stuff, having dementia can be a big problem. Again, mostly focusing on Alzheimer's, but most dementias are relatively similar in how they impact people and they impact the caretakers. Okay, so one of the things that, when I was in hospice, is one of the problems is you have people who are taking medicine for blood pressure, heart disease, etc., and they start getting them all jumbled, or they forget to take them all together, or they take them all together when they're not supposed to. So it's something that we want to know about so that we can, if we can, intervene with that. Forget to keep proper hygiene so they don't take showers, they don't take baths, etc. Bowel issues are a biggie as you get further along, mostly because we end up starting using medications that cause constipation. So unless you're on top of that and find out exactly how often they're having them, etc., they can get into real problems. Nutritional issues, mostly this is not eating, so they forget to eat. If they do eat, they don't eat very much, so weight loss is a real common problem. Again, as the disease advances, they can go out and wander. Every now and then you hear these stories about the nursing home where somebody got out. It was the middle of winter and stuff. They had trouble expressing it. So if they're hurting, you may not be able to tell you I'm hurting, you may be able to tell you I'm hungry. So that just makes it more difficult for us to sort of interpret. If they're agitated, the agitation may be the result of some discomfort that they're having, some pain that they're having, or whatever. So we need to be thinking about that. More likely to have mental health issues, especially as it goes along, anxiety, anger, psychosis, hallucinations, more motor problems. So it just not only affects the memory and stuff, but it affects their ability to get around. They are much more prone to falls and getting into trouble. So you have to look around. There are loose carpets on the floors, etc., that are creating increased fall risk. This is one that always scares me because I see so many of them that have it that are still out riding. It's like, you worry about them. I actually worry more about the other people that they're going to hurt and stuff. And this is a big negative impact on caretakers. Really takes its toll on people who don't have adequate assistance being able to take care of these individuals. Talk a little bit about anatomy. So we have over 100 billion neurons, and those neurons have over 100 trillion synapses. Okay, I'm going to take you back to high school biology a little bit here. So this is an artist's depiction of what it sort of looks like in the microscopic level. So these are all brain cells. This would be the main cell here. This here is something called an axon. So that's the basically the cable, the electric cable that comes off the nerve. And then these are all dendrites, and we'll move ahead here, but you can see that there's a lot of connections between those nerves. So microscopic even further. So here's the nerve cell, and this is the axon. So basically when this fires, it sends electricity down here, and right here is something called a synapse, right there. And the synapse is basically where two parts of the nerves, we call them the pre-axon and the post-axon, where they sit really close together, and the signal actually, so you have electricity coming down this nerve here. What it does is it triggers that synapse, the nerve ending, to release these vesicles into the synaptic cleft, and then they trigger this nerve to carry the signal on. So I tell people if you're familiar with spark plugs, spark plugs, when they fire, have a small gap that it has to jump. Okay? And I tell people that when you get something like the dementia, what happens is it's like a spark plug that's all carboned up or all fouled up. Signal comes down, fires, but it doesn't jump the gap. So this is one of the ways that we start losing some of the ability to go ahead and use our brains and all the nerves and stuff, is because these gaps are, these synapses and stuff don't work. So this is another artist's depiction, and I'll talk a little bit about it. But Alzheimer's basically is characterized by two things. One's called neurotangles, and the other is beta amyloid. So neurotangles means that when I talk about all those nerve connections from one to the other, they get all twisted up. And so once again, you don't get nice, consistent firing and connections between the nerve cells. This is the other part of Alzheimer's disease, which is beta amyloid. So this again gets in there, clogs up the nerve, interferes with that transmission from one part of it, from one nerve to another nerve. And again, going back to 100 million nerves, but 100 trillion synapses, that means that each nerve just has loads and loads and loads of synapses. So warning signs. Are they forgetting? Anybody in there? All right, so if that were the only criteria, I'd be writing in with everybody else. However, what you're looking for is that forgetting things to the point it disrupts daily life. Okay, we all walk into the room, have no idea why we walked into the room, but you come out and later time you come back and say, okay, now I remember. Do they have trouble planning or focusing on a detailed task? Daily tasks become a challenge, and they have trouble completing them. Trouble driving to familiar locations. So they go to someplace and they can't remember how they get lost, so to speak. Things aren't familiar, and then they get there and they can't get back because they don't recognize where they are. Conversations can become frustrating for both the person listening and the patient with Alzheimer's because they can't find the right words, they call things by the wrong names, etc. Okay. Do they lose things? Well, you know, that's about everybody there, okay? But usually, I remember where I put my car keys, or I remember where I put this or that. It may take me a day to do that, but I get there eventually. Or they put things in strange places, such as the keys in their refrigerator, okay? And this is another thing that happens because, again, of the memory. Things disappear, they put them somewhere, and then they start accusing other people of having taken them. That was a real problem. We saw that real frequently in hospitals when we were dealing with patients who were in stage dementia, and they would be after the family, and did this and did that, etc. Do they have lapses of good judgment? You know, are they giving money away to strangers, or it's not so much of an issue down here, but if you were wearing shorts and the white shirt in Colorado in December, that would be kind of problematic. Are they withdrawing socially? You know, are they decreasing their hobbies, watching TV more, sitting around more? And are they having mood changes? So are you noticing more rapidly changing moods, getting angry, getting frustrated, getting anxious, getting paranoid? All right. So I was going to end there because I think I've mixed up like 10 or 12 minutes and stuff. The next session is going to be about diagnosis and treatment. But questions today?
What about sundowners?
Sundowners is usually somebody who has some level of dementia. And the reason they call it sundowners is because it tends to occur late afternoons, early evenings, where you'll see more manifestations of all of these different things that I talked about, okay? But it is, you don't have sundowners as a rule without having some type of dementia there. They may function very well. In fact, one of the problems that frequently happen with the elderly with dementia is that they go ahead and they also have their heart disease with pneumonia. You pull them out of the home, you put them in the hospital, you took away everything that they knew or used to orient in the hospital, and then they go bonkers in the hospital where they function adequately at home because you've changed the environment. Any other questions? Okay, to be continued. And for the people here and those out there, I need topics. You need to tell me what you want to know. So I'm not just making up stuff and getting up your bladder. Okay? All right.
Thanks.